My name is Jody Gutkin. I am presenting today on combat-related polytrauma. I have been a physical therapist from the baccalaureate degree days back in the early 90s. Over the course of my career, I've had opportunities to practice in a variety of settings related to this topic. One of my early clinicals as a student was at a VA hospital, which is close to my heart. I remember the stories of my grandfather, my grandmother telling me about my grandfather. My mom was born while he was not at home. He was on a base. So I remember them saying that they decorated his bunk to celebrate the birth. So I definitely have in my heart this topic. I really feel the role of our veterans is so important, and our active duty members as well as reserves. In my clinical practice, I've worked with individuals with a variety of the diagnoses that we're going to speak about today across the continuum of care, from acute care to inpatient rehab, outpatient, as well as home care. I moved to Florida, so the skilled nursing facilities are also a setting I've practiced in. In my second life, I hold a master's in education. I have been a physical therapy educator for several decades. So I look forward to speaking with you about our topic today. To talk a little bit about what we're going to cover, combat-related polytrauma. This is a diagnosis that many of you may not have heard of. It's new terminology. So we're going to review what conditions fall under the umbrella of this diagnosis related to our veterans. We're going to look at the pathophysiology of the different conditions and gain an understanding of the different exposures they have while they are deployed that impact our rehabilitation when they return to us. We're seeing an increase in the number of veterans in the private practice arena, public rehabilitation centers also. They're all just not going through the VA. So it's important for us to understand as clinicians that the needs of this population are different, and we really need to treat them holistically because so many different body systems are involved. So we're going to look at how we can best support the rehabilitation of this population. We'll spend some time looking at the exposures while they are overseas. We'll take an understanding of the levels of care that they receive before they return to the continental United States. And we'll also look at some specific diagnoses and the current rehab trends and advances related to amputation, spinal cord injury. We'll talk about post-traumatic stress disorder also, as well as pain management to be comprehensive. A disclaimer, as with any course that you attend, you want to make sure that when you go back into the clinic to apply these concepts, that you do so in accordance with your federal, state, and professional regulations where you practice. There's a quote that I like to start with, and I will always do my duty no matter what the price. I've counted up the cost. I know the sacrifice. It's actually a lyric from a song, but I think it kind of sums up what our veterans and active duty military personnel do for us, that they are out there and they come back physically and mentally injured from doing whatever they had to do so that we can be over here living our daily lives. So they need to live with the outcome of those actions, and it's our role to support them to maximize the fulfilling life that they can have when they return. To give us an idea of the current military conflicts, we are still seeing veterans of World War II, the Vietnam War, in our clinics. In 1991, Operation Desert Storm in Iraq, we see veterans from that conflict. And then just to go a little bit into the terminology so that you're aware, the post 9/11 conflicts in the Middle East continue to evolve. Those are going to be Operation Enduring Freedom, then in 2003, Operation Iraqi Freedom, 2010, New Dawn, and then in 2014, Operation Inherent Resolve and ISIL. So there are still many military conflicts that are going on, all over different parts of the world, but specifically looking at those post 9/11 conflicts. This is the terminology that you may hear. The impact of these military engagements is significant. Trauma has been studied of our veterans almost in real time. These conflicts have been so long that we actually have individuals who are veterans from the conflicts that are currently still underway, which is just tragic, but the positive side is that the military has been able to look at the care that's provided, look at what's going on in the battlefield, and they're able to make real-time changes to improve care, which is so important. When we talk about our topic today, what I want you to consider are our active duty military that have now become veterans, retired military, the individuals who are in the reserves, the National Guard, and also individuals who may be civilian contractors overseas might have some of these same exposures that we are discussing. Now, when they come back to the United States, they may not be identifying themselves as having had those experiences. Most of the individuals are reintegrated into society, and they're not braggers. Like we would want to thank them constantly, but they're not. So we need to take a little bit of time to recognize who these individuals are so we can be comprehensive in our care. The survivorship of these military conflicts is the highest it has ever been from any military combat. 90% survival rate is unprecedented, which is wonderful due to the improvements in body armor, the vehicular body armor, as well as the personal protective equipment. There's more rapid aeromedical evac, and then cutting edge medical terminology has significantly improved the survival rate. And this is great. If we look at the military conflicts over time, we are up at almost that 90% survival rate for the current conflicts. This is based on data that has been monitored by the government. The challenge means that these individuals are surviving, but they are more medically compromised and have more diagnoses that we need to address. When we consider who our veterans are, these amazing men and women we see out in society every day, and we may not know it. They are in our workforce. They're our patients. They're family members of our patients and close friends. So we need to consider this. In 2017, the VA epidemiological program was tracking individuals from the post 9/11 conflicts. So they look retrospectively between 2002 and 2015 to see how these individuals were accessing their rehabilitation and medical services once they were back in the United States. And they found that over 60% of the veterans who were eligible for services, they did not opt to go through the VA for their services. They actually used their private insurance because now they're employed or their spouses and they're back in the workforce because they're a younger population, and they're utilizing those services. So we may not be aware post-deployment of these individuals. So we'll talk about how you can increase that awareness to direct your treatment. There are many different diagnoses these individuals are going to present with, from musculoskeletal to mental impairments from the exposures they've sustained. And then we also have this category of ill-identified conditions. And this is an array of different diagnoses that don't really fall into any other specific category. Because these individuals have multiple body systems affected, the military and the VA have identified this diagnosis of combat-related polytrauma, and they've developed specific centers and trying to increase awareness of the needs of these individuals. The U.S. service members are not just sustaining physical musculoskeletal trauma or organ traumas. They have multiple other body systems that are effective, physical, cognitive, and psychological. diagnoses that are falling under this umbrella they're not conditions that were pre-existing. So we're not talking about when we say they have comorbidities or multiple injuries, pre-existing conditions, maybe they have psoriasis. That's not what we're discussing. We're saying that because of the exposures, the weapons, the IEDs, just the environmental exposures, these individuals have traumatic brain injury, amputation, spinal cord, as well as visual and hearing impairments, and post-traumatic stress disorder. And this is in addition to any organ system or other physical traumas they may have sustained. They say that the average hospital length of stay for an individual veteran following a significant injury is about 41 days. And then when we think of these individuals coming into outpatient therapy, that there are many areas that we need to address, or if we're seeing them in inpatient rehab also. Let's understand a little bit of the risk factors and the exposures that our military personnel are exposed to while they are overseas. There are many different categories of exposures that can impact their ultimate functioning when they return to the United States. The first one we're going to talk about are sand, dust, and particulate matter. It's different environmental conditions overseas, that there are dust storms, and the large particles from the dust storms the individual can expel, and they do have personal protective equipment, but the research is showing that some of the small particulate matter cannot be expelled, and it actually is retained in the lungs and cause damage and irritation. They say that approximately 25% of the military personnel are exposed to at least 11 or more days a month during deployment where they are inhaling dust and particulate matter. So this can have a significant impact on their health moving forward and when we see them long term. Because we are still involved in these conflicts and we don't have a lot of long-term data, we don't know the eventual impact. So we need to be aware of this and be mindful of respiratory compromise. We're also going to look at all of these other exposures more specifically. Burn pits might not be something that you think of. Maybe you're treating a veteran or and because now they are working and return to functional activity, and maybe they sprained their ankle and now they're coming to you from rehab. It comes up that they were deployed overseas. You need to be thinking about this potential respiratory compromise that they have from maybe burn pit exposure, because you're working on endurance training and you notice a symptom and should be referring them out to a pulmonologist. So this is how you should be thinking about this information we're discussing today. To paint the picture for you, burn pits are used for waste management. The garbage men are not coming every Wednesday and Saturday to pick up the trash and the debris. So these burn pits include human waste, munitions, food, plastic, medical waste. Everything has to be burned to be disposed of. And in 2012, there was a report. They went out to the joint base in Balad, Iraq, and they took air samples, and they actually found that there was metal, soil, dust, and all of this particulate matter in the surrounding air samples. And this is important because there are individuals who are actually working those pits. Again, they have protective equipment, but the smoke exposure is going to spread. And they estimate that 96% of active duty military have at least one significant exposure to the smoke and the debris, that particulate matter from the burn pits. When you think about the volume of this, they say that the average individual created about 8 to 12 pounds of trash daily. So they're looking at burning 200 tons per day to get rid of it. So what they're finding in terms of this particulate matter and the impact on the respiratory system, again, they're still trying to figure it out, but they're finding more implications looking at not cancer, more so an implication on functional capacity in terms of respiratory compromise for these individuals. So something to monitor them for. Another exposure is to different infectious disease. There are inoculations and vaccinations. However, there is still significant exposure in different parts of the world individuals in, let's say, Southwest Asia, Iraq, Afghanistan, exposures that they may not necessarily have here in the United States. They found there are actually 9 specific pathogens that individuals are exposure risk to. I have them all named out here. We're just going to talk about a couple of them. Tuberculosis, we are all familiar with. The individual, maybe you're rehabbing them down the road because there's these pathogens, it's not always an immediate symptomatology that presents. Sometimes over time, the individual may develop the symptoms. So if the individual is coming to us, maybe they've gone through their VA rehab and now we're seeing them in outpatient, it may be early on after they've returned, or it may be years later. So we're going to monitor. Tuberculosis, someone may complain of chest pain, persistent cough, that high fever. Looking at brucellosis, this may be something that everyone is not familiar with. This is a bacteria from the consuming infected animal products, and it leads to joint and muscle pain that can be chronic for years. So part of the differential diagnosis, if the individual you think may have had potential exposure overseas, obviously we're not diagnosing, but if their symptoms don't fit with the musculoskeletal diagnosis you're treating them for, it may warrant a referral back for greater investigation. Considering West Nile virus exposure, this also years later can lead to musculoskeletal pain, weakness, GI symptoms. And we're going to look at those outside referrals if the symptomatology just isn't fitting. Vibration exposure occurs to our military personnel in several different ways. Their bodies may be exposed to whole body vibration from a piece of equipment they're physically sitting in, or they may have isolated hand arm vibration syndrome developed from utilizing tools and equipment where that vibration from the piece of equipment goes up through their extremity. So there are 2 main types of occupational exposures. It's important that when at the point in time we're seeing these individuals, some of you may be working in the VA rehab, so it's earlier on. Others of us, it may be more down the road when they're back in civilian life. We have to consider that if the skill set that they had while deployed is the same skill set and employment avenue that they have now, it may be adding to the vibration exposure. So if they were a mechanic or they were laying different lines and now they're doing that as their current work, they may be adding to their exposure. Let's look specifically at distinguishing these two types of exposures and how they present. Hand-arm vibration syndrome, when individuals are utilizing different types of equipment and heavy machinery, like a tool, they do have protective equipment and ergonomic handles. Ergonomic handle does not mean that it reduces vibration. That means that the joint alignment is appropriate. They should also be utilizing a glove or a piece of equipment that actually absorbs some of the shock and the vibration, so it's not transmitted into the hands, because that prolonged vibration in the hands, it causes damage to the endothelial layer of the capillaries. It can irritate the nerves and cause long-term damage also to the tendons. So the individual may present with this blanching of the fingertips. They are going to have numbness, tingling, decreased grip strength. And you might be thinking, wow, this sounds very similar to our differential diagnosis for carpal tunnel syndrome, rheumatoid arthritis, thoracic outlet syndrome. And that's what we need to do. We need to discern, is it previous hand-arm vibration syndrome exposure that led to the pathology, or is it a new diagnosis that we need to consider? Because they may have some residual deficits, and we need to look at work modification or maybe vocational rehab referral. Whole body vibration is going to be more of a low frequency vibration that is transmitted through the entire body. So think of individuals who are in heavy pieces of equipment. Maybe they're, digging trenches with large mechanical equipment, the heavy tactical vehicles, helicopters, our Marines on the ships all the time. Propellers, gearboxes in the planes. Just consider here an individual who is out on a hovercraft, those rigid inflatable boats. They are in military conflict. They are not thinking about their body mechanics and this vibration going through their body, but they have the vibration of the engine, the vibration potentially from the artillery, the vibration from the waves and the water. All of this is being transmitted through their body. And what happens over time is that there has to be micro contractions of the musculature, and some of that force is transmitted through the spine, which can lead to musculoskeletal damage for the individual. The Marines have also found that this is at greater risk for their population. So they actually have specific equipment. They have developed like these mobile workstations in the large ships that'll absorb some of the shock. They're also looking at like this cocoon kind of seat for individuals to sit in so that it absorbs some of the shock for the individuals. So kind of air ride seats. They're looking at live time trying to reduce these exposures to limit the potential long-term physical consequences as much as they can. Noise exposure, we need to consider. Hearing is the only sense that is on 24/7, 365, and there are many mechanisms in place for personal protective equipment, but it still is one of the top 4 injuries of the current theaters of operation, and it seems to be the most underreported because a lot of individuals don't realize it's happening, or it's just so continuous. Think about the different noise exposures and the fact that hearing does play a role in safety for interactions. It plays a significant role in balance that can have an implication for us down the road in rehabilitation. They say that the metal on metal from a munition hitting a vehicle or contacting another metal, that metal echoing reverberates, and that the discharge from every single type of firearm, it actually exceeds the safe levels for our hearing. Steady state noise is another potential exposure for individuals. Steady state noise is occurring in several different ways. Think of the military kitchen trailer, that it has generators that are running. Outside the sleep tents, there are generators for the air conditioning or the heating, and that has a steady state noise. What happens over time, it can cause exposure and gradually diminish the individual's hearing. A 4-hour ride in a Humvee, which is a high mobility, multi-purpose wheeled vehicle, 4 hours at about 40 minutes is the same damage to our inner ear or the same exposure as continuous noise as a discharge from an IED explosion. So just to give you an idea of this, steady state noise can play a significant role in diminishing hearing. So we need to assess that sense when we see these individuals in rehab. Depleted uranium. What happens in the attempt to try and make better body armor, better munitions, is that they've utilized depleted uranium, that it possesses the same radio activity as the original uranium. It decreases it a little bit. It's about 60% radioactivity, but the concern is that the chemical toxicity remains at a high level. So imagine these vehicles that are depleted, coated in depleted uranium to make them stronger. When they are penetrated, though some of that chemical is released into the air as particulate matter, and then any metal fragments or debris that may become embedded in the individual, that also has that chemical toxin on it. Think of the burn pits that this is being released into the air. So there's a concern of what is this depleted uranium exposure when it becomes internal in the body doing to the veterans. And there's two different ways. When it's inhaled, the concern is that it may cause lung irritation for the individual. The use of this started really around 1991 in the Gulf War, they said, but the exposure risk has increased in the post 9/11 conflicts. The VA says currently that there are no health complications, but they still need to research the impact of this because we don't have long-term reports. The World Health Organization concurs that we have to figure out what thresholds are appropriate. The concern here is if there are embedded fragments that have the depleted uranium on them, that those chemicals will leach out into the circulatory system and then place a strain on the kidneys and the other body systems for the individual. When we consider the blast injuries that our military service personnel are exposed to, and I will tell you, some of these images, when we move into the next hour or two, are going to become graphic. And please know that my heart is in all of this, but I have to remain very objective in presenting the information, or I'll probably cry my way through the whole presentation because I'm just so appreciative of everything. So when we look at these blast exposures, I want you to understand the physical trauma so you can be holistic in your rehab. In World War II, the Korean War, Vietnam, Persian Gulf, there were primarily thoracic injuries. As our body armor improved with the post 9/11 conflicts, there are different wound patterns with these IED explosions, that it creates a violent explosion that creates pressure, and then there's particulate matter and projectiles that are contained to cause even more sustained trauma, in addition to the heat that the individual is exposed to. There's actually kind of a tiering of the exposure based on the distance the individual is from the explosion, and they will receive, unfortunately, multiple levels of trauma and blast injury. We're going to hit on the pieces that are relevant. And again, I want you forward thinking to the assessments that you need to do on the individual to be holistic, whether you're treating them for rehab from this original injury or later on in life because they have some other new diagnosis unrelated. They may still have system impairment. Initially from the blast injury, the barotrauma damage that occurs from the pressure of the blast is going to impact traumatic brain injury, the GI system. More of our hollow organs will be damaged from that. Looking at those projectiles and the fragments that are released from the explosion as a secondary injury, the debris can penetrate into the soft tissue of the body, causing eye damage, organ damage, and other soft tissue. Just from the pressure of the waves, there's impact injuries, which is a tertiary injury that occurs. They say that the pressure of that individual's body being physically displaced leads to head, neck, other fractures and trauma. And it's similar to a fall from a high height or a vehicle ejection. That's the level of force from these injuries. And then additionally, there could potentially be thermal bones burns, as well as chemical and biological contamination. So many things to think of. Dismounted complex blast injury is a diagnosis that has increased since 2010. In that year, there was increase in the number of foot patrols and ground patrols that were utilized, and unfortunately, the exposure to ground IED explosions had increased. So because there is good body armor, unfortunately, it led to significant amputations in the lower extremity and then also in the pelvic area. So these individuals, in addition to many of them having bilateral amputations, they have significant pelvic wounds, the genitourinary system is compromised, and then the traumatic brain injury from the pressure. So that's that polytrauma this individual has also sustained. So as this population aged, we really need to pay particular attention to that genitourinary compromise, decreased mobility, and potential implications. As I mentioned, the toxic embedded fragments from the different explosions that occur the fragments can penetrate into the individual's body. The way that they decide whether or not they're removing a fragment from the research I completed is looking at the proximity to neurovascular structures, the size of it, is there a risk of infection because of its location? And then if it's on weight-bearing surfaces like the hands and the feet, they'll be more likely to remove the fragment, or if it's a potential to cause chronic pain or arthritis. But sometimes they may leave the fragment in, and the concern is because there is different chemicals or maybe that depleted uranium, it is going to leach out into the body system. The systemic compromise can be significant to the kidneys, the neurologic system, so we're going to monitor these patients. They've actually set up a monitoring system in order to determine the potential risks for these individuals. So anyone who has a fragment that does become dislodged or they have it removed, they're supposed to return that to this surveillance database so that it can be analyzed. And if you have a patient that needs to be monitored, if they have any kind of fragment, they should be registered with the VA for this monitoring system where they'll go for periodic urine analysis to see if there is any leaching out of chemicals to try and catch it sooner rather than later to provide care. And the care that the individuals are receiving is extensive. There's actually a progressive system of care. It's called tactical combat casualty care. So everything we discussed up to this point are all of the different exposures that the individual is at risk for. When there is actually an in-battlefield injury, there's a specific way that care is provided that we're going to take a look at, so we have that perspective of what the individual has gone through before they get to us. Looking at all of the different exposures, the current military medical care doctrine is damage control, mobility, and temporary measures, because oftentimes they are still under fire, they're still involved in this tactical operation here, and care needs to be provided, that it is a balance between the two. So these next couple of images may become graphic. If you're in a public place, you might want to turn your screen, or if you have children around, this might be the time moving forward to not have them viewing with you. We're going to look here at an example of how care might be delivered. This is at a 10,000 foot altitude in the Hindu Kush mountain of Afghanistan. This individual in the image here has sustained a right hip injury. There's a shrapnel wound. Imagine the conditions that care is being rendered under. They're still under fire. It is cold, it is dark, they have limited equipment, and ultimately, when this individual heals, they may be seen by us. This hip wound is going to look very different than that individual who had a nice total hip replacement and has a linear scar. One piece of equipment that they'll utilize in the battlefield that has played a significant positive role is the tourniquet. To give you a little bit of a history on the tourniquet, it's one of the primary tools that's utilized in what they call damage care resuscitation, and that's what they provide in the battlefield. Looking back at World War II, they used straps and buckles to try and create a tourniquet. Going forward into the Vietnam War, they actually went back retrospectively and looked at the individuals who did not survive their injuries, and they had determined that somewhere between 30 to 60% of the injuries that were sustained, had a tourniquet been applied, potentially they could have limited the significant blood loss for the individual and potentially saved their lives. So moving forward to the Gulf War, they still hadn't really changed the tourniquet very much. And now currently they've realized that having a tourniquet to stop the bleeding and preserve that limb and preserve life is so important that they have improved the use of the tourniquet and the design. The modern tourniquet, if we look at the top image here, this is a tourniquet, the straps that were utilized previously to try and control the blood loss and salvage that limb. On the bottom here, this is the current combat application tourniquet that's utilized. It's standard issue for all military personnel. They are trained in how to apply this. And the thought is that if they can stop the blood loss, they can preserve that individual's life. So they're actually instructed they can apply it over their clothes and apply it themselves to stop that bleeding. Originally, they thought that tourniquets would cause too much tissue ischemia, but then they realized even if we put a tourniquet on, if it takes 6 hours, about they found you can have a tourniquet on before it starts having a negative consequence, that the benefit of the life-saving measure outweighs that potential risk. As we look at that individual from the battlefield going through the different levels of care that they receive, ultimately to rehabilitation, it's what called echelons of care. Those are the different levels and service of care that the military provides going from battlefield forward. To give you an idea of the timeline, generally, if there was let's say, a tragic motor vehicle accident here, or individuals with significant injuries in a motor vehicle accident, in the civilian sector, within 20 minutes or less, most individuals are at a hospital receiving a high level of care. Out in the battlefield, what they look at is within an hour, they're trying to get that evac to surgery. When an individual progresses through these different echelons of care, we're looking at this new structure that was established by the military in 2003. It's a long process, but there are small increases in the level of service that's provided as they progress through. Level 1 is care under fire. So this individual is in field, that they are, maybe it's referred to as tactical field care. They may still be in the middle of a combat operation when they sustain their injury. So the goal is to preserve life as well as complete the mission. Care may be provided by a combat medic. Maybe the soldier themselves is applying that tourniquet. They have to come up with creative ways to communicate. So on the right here, we see an individual. They actually use the dressing to document. They're not pulling out their computer doing computerized documentation. So they actually wrote across the top of the seal on the wound, skin only closed, damage control laps, 10 laps are surrounding the liver, to communicate to the next level of care what that individual has received. Where this individual may be evacuated to is a level 2 forward surgical team. This is going to be a little more removed from combat. If we look at this, we're thinking they're going to a hospital. These are still tents, but they are very well supplied. If we look on the right-hand image inside here, these are usually manned with 5 to 20 personnel that would include an orthopedic surgeon, an anesthesiologist, a critical care nurse. They have labs, they can do imaging at this point in time, and it's trained staff. So at this point, the individual is going to receive attention to their airway, breathing, circulatory system. They can do some life-sustaining surgeries in these mobile units, and they can perform about 30 surgeries before they have to be replenished. So they are able to provide care out in the field relatively quickly. Some individuals need to escalate to a second level of care. If an individual cannot return to duty following the care they receive at the level 2 facility, they may be transported to a level 3 combat support hospital. These are modular hospitals. You can look at the image on the right. Again, not what we think of like a level 1 trauma hospital here in the United States. However, the same level of care is provided at these facilities. They were previously referred to as MASH units. Back in 2005, to give you an idea, there were about 5 overseas in the region of the post 9/11 conflicts. They're transported there usually via helicopter. About 100 patients can be receiving care in these facilities at a time. Again, it's visually not what we picture, right? If we walked into this here in the United States, we might want to turn around and leave. However, this is providing high-level care. This is the first ICU level care that the individual can receive. There are surgical suites, and at this point in time, they will either return to active duty, or if they need a higher level of care, they will be transported to the next level, which is a level 4 critical care aeromedical transport team. And this will take them out of the combat zone to a medical center, such as in Germany, transported to a large hospital out of the combat area. The individual will then receive all of the care that they need. Look at the left-hand image here. These individuals are receiving care even as they're being transported. Picture, this is your medically compromised patient, and they will be taken from the desert to the hospital. across in another country. So these individuals have significant equipment with them. There are providers with them giving care even en route. And then when they receive care at the facility in Germany, either at that point they will return to service or need to come over to the United States. At that point in time, if they have to come CONUS, which is continental United States, to a facility, those medical facilities, they have different specialty centers that are part of the VA network to provide the care that the individual needs. The stateside VA service network system is set up into regions. And then in the different regions, they have specialty centers in different parts of the country. So for polytrauma, like we're discussing today, because it has very specific needs for that population, there are specific polytrauma centers that that individual may go to. Or if they have burns, they may go more to the burn center. The idea that the VA uses is called a hub and spoke model of care to be most effective in the services that they deliver. So there'll be that primary specialty center that I mentioned, and then the spokes coming out are other support clinics in different areas. So the specialty center is going to be in more of a regional area, servicing a large area, and then our spokes here are going to be more of our local facilities that the individual will go to, and they can communicate with each other to provide comprehensive care. What they're finding is that it's still not enough. That there are too many veterans that need too many services, and some of them have to wait over 30 days for an appointment or travel more than 40 miles to receive care. That's one direction. So that really isn't effective, and that is not giving these individuals what they deserve. So what they started in 2014, and it received additional funding in 2017, is the Veterans Choice Program. And some of you may participate in this. You may not even know, but it's something to ask at your facility. The Veterans Choice Program allows facilities that are not part of the VA network to register for this system to provide care to our veterans as they're receiving their veterans benefit. So basically you become almost like an in-network provider, if I need to associate it to similar terminology. So you may be treating individuals who are receiving their veterans benefit, even though you're not at a VA facility. So it may be for their primary diagnosis or a secondary diagnosis. And this is a way that I like to think that if you're looking for a way to say thank you and a way to, do something extra for this population, speak with your facility and see if you can enroll or your facility can become part of this network to expand opportunities available for our veterans to receive the services that they need. Another benefit is that if you become part of the Veterans Choice Network, you receive access to the electronic health record, and it's through an encryption. You get a passcode, but then you'll have the knowledge of all the different exposures, all the different care. You'll have access to the other members of the healthcare team to make easier referrals to make this comprehensive care easier. A couple of key individuals with the veterans program that you might want to be aware of. The case manager is someone who will be the primary point of contact for the individual if you need to make referrals to other healthcare providers. And then please don't forget the benefits counselor. Our patients are with us, they talk to us. We may be the one hearing that they have a housing situation or they need to change jobs because of the physical impairments that they still have, or they need that referral out to the ENT to see maybe they have a hearing impairment and now they can't return to their previous job. So the benefits counselor is going to help look at those other socioeconomic workforce type aspects to make sure that the veteran is accessing all of the resources that they are entitled to. When we're transitioning into these civilian rehabilitation settings, we need to consider this population again, we're seeing more of them. There was a study that looked at between 2014 and 2015, there was about a 6% increase in the number of veterans who are being seen by community partners. And this, they say, is going to continue to rise as that Veterans Choice Program continues to expand. So the research went a little bit further, and we said, okay, if we're working with this different population, are we educated in this? Because I can tell you, looking back at school, even though I did have the opportunity of completing one of my clinicals at the VA, we had no education on this population and their specific needs. And it's something that has been analyzed. RAND did a study in 2015, and they looked at how well prepared clinicians are. They started with mental health practitioners in this study because they felt that they should have been most educated. They found that only about 70% of the VA providers really understood the needs of this population. And looking at community partners, only 24% recognize the diverse needs of this population and could tap into what's necessary to appropriately treat them. So they said that there's an initiative now to increase awareness and try to include in educational programs recognition of this population and really an understanding specifically of the military culture. So this course is another way I'm trying to say thank you and tap into that. Understanding military ethos, we need to take a minute and think about that these are the values, the attitudes, the beliefs, the guiding principles of this population, that selflessness, teamwork, and being of service to others. Think about how that transitions into the clinic. When the individuals are in the war zone, they are not physically safe. They need to act, then think. They know to follow orders, and they need to shut down their emotions. Now they're in civilian life, and everything is the complete opposite of that. That we have individuals who are now at a point where they, we're asking them about their feelings. We're asking them about what they want. What do they think? And they may not be used to that. The mindset may be a little bit different. I want you to consider things that when the individual is in the clinic, just what time of day you're scheduling them. Because, and think about this, you're the clinician who's always running late. Whatever patient you're with, you're giving them your all, and maybe you're just a couple minutes late every time. Your veteran patient, who is the one that's maybe waiting for you, they may not tolerate that well. Punctuality, accountability, being where you're supposed to be, doing what you're supposed to do, when you're supposed to be doing it is highly regarded. If you're always those couple minutes late, even if you're giving them 1,000%, that may not sit well with them. It may not set up a great interaction. Think about the patients that you seat them next to. Are they going to want to talk about things that maybe the veteran isn't comfortable with? They may not want to talk about their military service all the time. They may not want to have those big discussions. Think about what's on TV or on the radio station your clinic is playing. Is it something that could start a conversation or make your veteran potentially feel uncomfortable? That's not why they're there in rehab. Also be aware of the physical gym space. They're used to being hyper vigilant, on duty, assessing things, looking for threats. Combine that, maybe they have traumatic brain injury, maybe they have a little bit of hearing loss, and how this is going to impact them. Maybe don't schedule them at the busiest time of day in the clinic. Maybe sit them next to the window or give them a choice if it feels better for them to have an evacuation route. Think about these things. Don't make assumptions. I'm just throwing out some ideas so that you can be most comprehensive and set the right stage for your interaction. There are a couple lists of do's and don'ts that have come out in the research. It's okay to thank them, but you don't want to bring up a constant conversation about their service history. And remember the individual's own identity. Military service is part of their identity. It's not their entire identity. Our patients are working with us. They are communicating. They're talking to us. Things come out in conversation where with this population, you need to be thinking there's an opportunity for a referral source. You should be thinking about that for all your patients, but particularly with our veterans, with our military reserves, National Guard, Coast Guard, that there are specific resources that are already set up, and it's just a phone call or a web link to get that referral going. So I want you to consider that everything plays a role in success for this patient, their home situation, their employment, as well as their mental health. Imagine your patient has diabetes. Maybe they can't work because of their disability, whether it is related to their service or now maybe they've just become injured at some point later on in their life. They can't work. Their income is diminished. They can't buy appropriate food. Now maybe their diabetes has become not managed appropriately. Their blood sugars are fluctuating because their diet is poor. They're not healing well. There's a ripple effect. There is a referral source that you can direct that veteran to maybe get them some extra funds for fooding or look at job retraining or a stopgap in between. So think about these things, and all the referral sources that are available and all the references that I mentioned are on the last couple pages after the PowerPoint presentation in the course notes packet. Looking at mental health is an important piece for this population. And there's this app that's actually recommended by the VA. It's called a T2 Mood Tracker. Interestingly enough, it was developed by an organization within the military. There was a competition that they had, an Apps for the Army competition, and this won. The individual may not realize how much their mental health has been impacted because of their service, potential PTSD, just everything that they're managing in order to accommodate back into civilian life. So this app allows self-monitoring. It's completely anonymous. Nothing is being tracked for the individual. It's password protected, but they can monitor anxiety, depression, post-head injury symptoms, PTSD symptoms, and it provides links. They actually found that just having the individuals start doing some monitoring improves their mental status because it's giving them some of that power and control back so that they can make appropriate decisions. Homelessness. This is tragic that such a significant number of our veterans are homeless. And this includes those individuals who are homeless, about 40,000 as of 2016, and of those 13,000 are actually on the street and unsheltered. So there is a big push to try and decrease homelessness. This map demonstrates the across the country, they are trying to eradicate this problem. Since 2010, there's been a significant decrease by 50%. They decreased this number of individuals that are homeless. Just between 2015 and 2016, they went down another 17%. And there are actually 3 states now who do not have any homelessness among their VA population. That's Connecticut, Delaware, and Virginia. And they're trying to improve this even further. Something that you can do, because you may, this is a proud population. They are not going to bring this up necessarily. And we want to gingerly be aware of this. So one thing that you can do, there are these posters that you can request to hang up in your clinic, maybe just hanging them up in the waiting room, because the veteran himself, maybe they will call for assistance. Maybe there's a family member or a friend that'll reach out and make a referral. So little things that we can do to try and help. The same thing is true looking at that return to work opportunity. We need to give the individual that opportunity not only to provide for themselves and their family. There might be a need for workforce retraining because the skill set that they have, maybe physically they're unable to perform those same tasks because of the disabilities that are remaining. So they may need a change. So another poster that you can hang up, you go online and you request a copy, is looking at the Project Hired, which is part of the Wounded Warrior Project. It will help individuals look for jobs, gain computer skills, and make those transitions. We need to know first that our individual is a military service member so that we can have this increased awareness and make the appropriate referrals and screen appropriately. We're going to consider the whole person in our rehabilitation intake and our assessment. And something we need to consider incorporating is a military service history assessment, just so that we're aware. And then we're going to look at respiratory, acoustic, and visual impairments, including additional assessments in those specific areas if there has been military service. What's recommended to broach this is a little intake form. There are about 4 quick questions that you can add, and I have them listed here. You can include this just on your intake, so it doesn't need to be a face-to-face conversation. So I would encourage you to consider adding this for all patients. Would it be okay if I talk to you about your military experience? Obviously, the first question has to be, do you have military experience, service history or experience? And then there are questions asking if it would be okay to talk about these different situations. That will then give you an idea of outside referrals also that you can make. It also will give us that context for our future interactions. We will know the individual's background a little bit more so that we can treat them appropriately. Some military terms that might come up. The DoD has a dictionary of military terms. It's 394 pages. I'll be honest, I'm a research crazy. Those of you that have taken my courses, you know, I can't stop myself. I read a lot of it. I pulled out a couple here that you might hear that would be terminology to have you start thinking that you may need to assess for these different exposures. If you hear downrange, that means physically in a combat zone. In country means physically in a war zone. So in theater, they're in that geographic area, but not necessarily in the major combat operation itself. So some terms you might hear that would lead you to believe that you should complete some of those assessments for the additional exposures. The medical surveillance of the embedded fragments, if it does come up that the individual does have a fragment that is embedded during your assessment, the VA Toxic Embedded Fragments Registry is what they should register themselves with. This will allow them to receive the blood and urine screening to assess if any of these chemicals and toxins are leaching into their systems and potentially creating other damage for them. As of 2012, they had analyzed over 800 different fragments from over 300 different patients. They did find that there is increased metal in the body region surrounding where the fragment is in the tissues, not necessarily increased cancer risk, but compromise to the renal system, the immune system, the reproductive system, primarily. So If your individual is reporting compromise to those systems that really doesn't fit their diagnoses, that would be your red flag for referral out. When you assess for the respiratory system, we're thinking about exposure to those dust storms, the burn pits, the depleted uranium. When they were tracking the ICD-9 codes, so this is going back a little bit, back in 2016, they did a retrospective analysis from 2002 to 2011 to look at the different diagnoses of individuals from the Iraq and Afghanistan conflicts. And with over 700,000 veterans, they did find that about 4% of them were presenting with either asthma, COPD, or interstitial lung disease. That is after accounting for tobacco use, that they did still find an increase in lung disease. So interstitial lung disease is a progressive scarring of the lung tissue that leads to decreased expansion and respiratory capacity. What you might want to consider adding, and how do we actually assess for respiratory compromise, is possibly a 2 or 6 minute walk test to look at that respiratory endurance. If you're assessing for the difference between asthma versus tuberculosis, both of those conditions are going to present with that tightness in the chest as well as shortness of breath. The big difference is asthma is going to have that trigger, non-productive cough, as well as wheezing. It tends to be more environmental. Tuberculosis, symptoms that you're going to monitor for, it's usually unilateral. It's isolated to a lobe or a region of the lung. If you auscultate, what you'll hear are rales, maybe some crackling or rattling. What you hear is as the byproducts build up from the infection in the alveoli of the lungs, when the individual inhales, they kind of pop open, and that's what you hear on auscultation, that fluid and exudate kind of moving around as the air is inhaled. So this will be more of a productive cough with systemic symptoms of malaise and fever. So either one of these will require a referral out to a pulmonologist. Obviously, if you're concerned about tuberculosis or some other infection, that would be a more immediate referral. For the acoustic trauma, the way that we are going to assess for the potential cochlear or inner ear damage from the blast or that continuous noise exposure is looking at, does the patient complain of otalgia? So do they have pain in their ear? Are we seeing balance deficits or potentially a hearing loss? Maybe some vestibular impairment is evident. When we look specifically at the different auditory impairments that the individual is going to present with, we're going to look at what are they hearing and how are they hearing. If we think of the average 70-year-old, we can kind of envision about how well someone 70 hears. If I said the person's name Sue, S-U-E, Sue, what all of you are hearing is the S-U, the whole term, whole word. So the S is about 6,000 hertz. The U is about 200 hertz, so it's lower. As we age in this individual with the specific acoustic trauma that we're seeing, they're still going to hear the low frequency, the U. What they're going to lose are those high frequency sounds, so the S. They're going to lose S, sh, t, k, ch, f, those different sounds, high frequency sounds. So it is going to be difficult for them to hear when there's a lot of background noise. So think of how it is in the clinic. Are they reporting, or are you noticing they're saying things like people don't speak as clearly? So that might let you know there is some diminished hearing. And something that you can do is a localization test, so a directional localization test. So maybe you're in the loud, busy clinic, you're standing afar from the person, not making eye contact, and you go, Mrs. Smith, over here, and see if they can hear, and then directionally locate where that came from to make eye contact immediately with you. That is a quick way. It might give you a little idea if they have loss of that directional localization and may need a referral out to an audiologist. When we look at visual impairments, there can be trauma to the eye in several different ways. Sometimes it may be obvious when you're assessing your patient. In this image here, if we look up right here at the 10 o'clock position, right there, what we are seeing is the iris is trapped outside from a penetrating injury for the individual. The estimate is that about 10% of blast survivors have some type of eye trauma. And just looking at not this type of injury, but visual impairment in general, about 50 to 75% of individuals who sustain a traumatic brain injury do have some type of visual disruption. It may or may not be permanent. So this is definitely visual assessment is something that you want to include. It may be something that the individual doesn't even recognize over time is related to exposures that they've had during their military service. There are specific blind rehab services because this population is going to get older. And when we combine a potential traumatic injury or just from the blast exposure or head injury, decreased visual impairment, with aging, glaucoma, retinopathy, it may lead to greater visual impairment. So the blind services with the VA is a great resource for these patients. When we look at vision assessment, I think OTs get a little more education in school about this than PTs overall. What we're looking at, there are many different types of visual assessments. We are looking at, do they have difficulty focusing for prolonged periods of time? If they, let's say you have them doing exercises and then you hand them papers to look at a written home exercise program, are they able to focus right away, or do they say, wait, give me a minute, I can't see? That might be your clue that they need a vision assessment, that adjustment period might be slower. Be aware that when you're shifting between different activities for the patient, they may need a little more of an adjustment for that near-far acuity when you're doing different functional tasks and activities. Convergence is another area that you might want to do some assessing. This is where both eyes are looking simultaneously. It plays a role in our depth perception, which also contributes to balance. The way that you can assess for convergence is you can just ask the patient how they feel when they're doing reading or close work. There's actually a survey form that I have links to at the end of the notes packet. And when you look at a scoring on this assessment of how they feel when they're participating in different visually challenging activities, it will give you an idea if they need a referral out to an ophthalmologist or an optometrist. Also, if patients are saying they have, eye fatigue, dizziness, headache, balance deficits, that might be a hint that we need to look at vision. The Snellen eye chart is that typical eye chart that we are all aware of with big E on top. It was actually developed back in the 1860s and really hasn't changed because it still works. They cover with not their hands. You're not supposed to use. You should use a paddle or a paper to cover one eye. They stand 20 feet away from the chart, and then they see what line they can read. Those numbers down the side of the chart, let's say someone scores a 20/40, that's the line they can read. That's going to show that you need a referral out. The 20/20 line is the line that someone with normal vision standing 20 feet away, what they can read. Now, the cheat for those of you in the clinic who are assessing this, because if you can't read it from the distance, it's DEFPOTEC, DEFPOTEC. So I never fail an eye exam myself. I actually have to go for one, and I'm going to have to be honest and tell them I know what it's supposed to say. I also know I have visual impairment. So that's the shortcut there. If your patient is unable to stand or you can't get them in a vertical position to look at that chart mounted on the wall, they make Chronostar pocket acuity tests. So what they've done is they've made it handheld so you can put it in front of the patient, and they've adjusted the size of the font so that it'll still come out with a reading for vision out of 20/20, even though it's closer to them. The Amsler grid you might want to consider utilizing for patients to give you a little more information about metamorphopsia. This is looking at a distortion of vision. So you have this little grid here, and the individual is going to stare at this dot in the center. If they wear glasses, they'd have their glasses on. And as they're staring, you're going to ask them, are there any breaks in the vertical and horizontal lines? Or are there any lines missing or wavy? If they have a loss of here, they don't see any lines in the center, that central vision, that might let you know macular degeneration. Maybe they say, well, the top left-hand corner here, the lines are wavy. So this might, again, give you a little hint that there is some type of visual impairment, so you want to make that referral out. When we look at low vision education, there are many resources that are available. The VA has that you can refer out. In general, with our patients, what we want to consider, looking at all of the different comorbidities, some simple things, make sure that they remove all the clutter, that they have a clear path to the bathroom at night. Think if they do have that genitourinary trauma, and they have decreased balance because of their vision, you want to make sure they can safely get to that bathroom at night. Contrast is so important. If they have grab rails in their shower, don't make them white on white, the same color as the shower, because they may not be able to see them. Just when the individual is eating, if they tend to eat bright colored foods, lots of fruits and veggies, have a light colored white plate so it stands out on contrast. When they're trying to fill a cup, maybe they keep their finger, over the edge into the inside of the cup as they're pouring so they can feel the level of the liquid, assuming it's not hot as they're filling it. So there are lots of different things that we can do for low vision education for our patients. Technology is expanding to assist this population. When we look at the advances with smartphone applications, what can be utilized, it's amazing what is out there. The data says that there are about 150,000 veterans who are considered legally blind, and then another 1 million who have low vision. That is impacting their ability to perform their ADLs. And as this population ages, we're going to see a natural decrease in their vision from aging combined with the damage that they already have. The smartphone applications are being utilized to help individuals with directional assistance. What they are starting to do in certain areas, they're testing this. There are Braille signs on different buildings, but you have to get close enough to actually read the Braille. They're starting to put little radio frequency monitors in there, or chips, that then connect to the smartphone, similar to, let's say, like an Easy Pass when you go through tolls, so that when the individual gets close to the building or the room, they could have read to them from their phone, from the signal on that chip on the wall sign, give them an auditory cue of what door they're at or building they're at to assist them in locating their physical geographic location. I think the most fascinating one is hand sight. This is amazing. It's this tiny little camera that's embedded on an artificial nail, and then when the individual scans it across a page with text, it's connected to their smartwatch and it'll read the text to them. And the expansion is that the individual can have, let's say, different hangers and tags for their clothing that tells them, this is a black and white striped shirt, or this is an orange t-shirt. If they run their finger across that, the hope is down the road that'll tell them what the clothing is so they can match their outfits. So all of these tools are designed to kind of restore that independence for this population, and many things start in the VA and then we see them used with the general public. That's our base. Those are just the body systems that we need to look at to prepare to treat the primary diagnoses that we're seeing the patient for. And some of those primary diagnoses that fall under our umbrella of polytrauma are amputation, spinal cord, traumatic brain injury, post-traumatic stress disorder, as well as chronic pain. So we're going to look specifically at some of these diagnoses now. When we understand the types of amputations that are occurring in the combat zone, it's related to explosions primarily, followed by gunshot wounds. In both of these cases, the wound pattern is not the same as that individual who had venous insufficiency and developed an ulcer and now has a transmetatarsal amputation. Or even that individual who was in a motor vehicle accident and had a non-union fracture of their tibia, and now they have a transtibial amputation. These wounds look very different. From the blast injury, primarily we're seeing involvement of the lower extremities and potentially upper extremities where the majority of the injuries are occurring. Again, we're going to move into some more graphic slides at this point. This is an image resulting from an explosion. This blast injury led to significant amputation here on the right side for this individual, massive limb loss as well as other damage. We can imagine that there's probably organ damage also, but individuals are surviving these wounds. That is the upside. So when we rehabilitate this individual, we need to consider what does this wound actually look like and how do they manage this? We need to understand where it's coming from to understand how to treat it by the time they get to us. Traumatic amputations have significant hemorrhaging. As we mentioned, they're utilizing the tourniquet in order to try and limit the bleeding to allow the individual to have life-sustaining measures. When they look at this individual, if they are able, on the right-hand side here, they have that cat tourniquet, the new style. If the individual has the pelvic trauma or a high transfemoral amputation, they make a pelvic band with a little pad in it that inflates to give the compression, because you can't apply a tourniquet necessarily. So they have different kinds that can be utilized to stop the bleeding for the individual. Battlefield management used to be they would do a cylindrical amputation for that individual. That is not the case. Now they say the goal is to try and salvage as much as they can so that surgery down the road can retain as much of the limb as possible. We know a longer limb allows for better function, less energy expenditure. So what they're looking at is in the field, they apply skin traction to try and traction down the residual skin that is left. And then in the bottom image here, we see that they apply a bivalved cast to the area to give some compression to the region. And then that individual is stabilized and can go through the transport chain to evac and then receive care for debridement of that wound and eventually wound closure. The follow-up Medicare that the individual receives going down the line after they're medically stable is at some point they're starting to use the negative pressure wound therapy for these individuals. Because of the amputation, they don't have the skin flaps to cover the distal end of the amputated limb. So what they try to do is by tractioning that skin, or this is an example of a wound vac on a different area, not an amputation. But once the wound is clean and debrided, what they can do is apply the negative pressure wound therapy and to assist in closing that residual limb. And if they can get it small enough and have it granulate in sufficiently, maybe they can just do a smaller skin graft for closure and some flap coverage for those individuals. They're finding that the negative pressure wound therapy increases granulation rate. It's decreasing the bacterial colonization, which is important to decrease infection. What they then do is they try to get enough skin tension in order to allow the individual skin to grow over, so they only need a small graft. On the bottom left-hand side, what we're seeing here is a skin traction that's applied. So they take, and it's zigzagged in here. I'll zigzag. enhance it. So it's zigzagged that way. What they'll do is they'll kind of lace the edges of the wound and give it some traction to the skin so that as their epithelialization occurs from inside the residual limb and the skin is granulating in and epithelialization is occurring from the wound margins, it doesn't retract back. So they keep retightening a little bit to try and shrink that wound. And then on the right-hand side here, so they can eventually do a skin graft over that area. When they skin graft over the area, what they do is they mesh it. So it looks kind of like a lattice. So with a small skin graft, they can cover a larger area. Because think, if this individual sustained a bilateral amputation and then they have other physical injuries, where are they going to take the graft from? So they want to try and make this wound closure as small as possible. What we need to think about is this individual on the left-hand side is their traumatic amputation, and on the right-hand side, we're seeing their wound scar. That this is very different patterning and scar tissue that's going to result than in our traditional civilian population. It's great there's closure, but this person may need more scar work. Imagine trying to fit a prosthesis on this limb. It's going to look very different, so we need to be more attentive to that. Care and assessment of the residual limb for our veterans. Overall, looking at rehabilitation outcomes for this population, in 2012, the VA performed a study, looked at 1,300 veterans who had amputations. They compared their functional status, their psychosocial adjustment, and overall what they found is for 91% of individuals with lower extremity amputations, they felt that their life is full. 98% of them said that they are generally satisfied. Unfortunately, for individuals with upper extremity amputation, only 80% said that their life is full, and about 90% of them said that they, were completely satisfied. So we're seeing a significant difference in the outcomes for our upper and lower extremity amputees. The upper extremity is utilized more for functional tasks, so it may have more of an impact on the life for that individual. When we look at advances, they're trying to tackle that more, that they want individuals to get back to function, get back to work. So they're looking at prosthetic advances to improve outcomes for the patients. So patients are younger, they're surviving, they have long lives, they're reintegrating into society, so they need functional prostheses. There was an 8-year-long research study that was a joint venture through different organizations, and the VA ultimately released the LUC arm, which is abbreviation for Life Under Kinetic Evolution. It's an upper extremity prosthesis that this gentleman has on. It allows for 10 degrees of freedom for upper extremity motion. And the individual was able to, he's drinking a glass of water here. They said that he was able to participate in some light cooking. The arm tends to move more as a unit. Anyone who's worked with the old style harness type upper extremity prostheses, in order to control the elbow unit, the individual would have to do different scapular motions to lock or unlock the elbow. Then they would actually physically have to turn the hand for pronation supination and then do different shoulder motions in order to open and close the hand for functional tasks. It was very time-consuming, energy expenditure, irregular movement patterns, and many patients decided they didn't even want to use the upper extremity prosthesis. Advances now are allowing significant improvement in function. This is one example to allow more functional use with the prosthesis on the upper extremity. What they've started using on the lower extremity, and this usage may expand, is osseointegration. We said that those residual limbs are irregular shapes. Many may be too short or have too much scar tissue or irregular shape to them for a good suction socket. So what this individual has here is they started implanting in 2015. They did the first implantation of a implant into the femur, similar to a total joint replacement. It has a trabecular surface to grow into the bone. Then after that is healed, they go in for a second surgery. And on these particular individuals in 2016, so a year later, they went in and they put in a port that is going to stick out here from the individual's residual limb, and onto that they attach the pylon for the prosthesis. So it completely eliminates the need for a socket. So the individuals, they're finding that this is allowing for better, quicker donning and doffing because there is no socket. They have better control of the residual limb. Skin breakdown is not a concern now because we don't have that socket-skin interface if the volume of the limb is fluctuating because maybe they also have kidney disease. This is now not an issue. So they're starting to perform more of these type of osseointegration prostheses. Looking at other components of the prosthesis, powered ankles are being utilized more to allow replication of our normal ligaments and tendon gliding and movement. In 2007, the Biome ankle was introduced as a joint venture from MIT, the VA, and Brown University. And this is actually available on the market now. That this is kind of spring-loaded and it has a little motor in it to allow better accommodation to different surfaces. And what they found is that the powered propulsion from the mechanism in the ankle is allowing for better mobility because it actually emulates our normal musculotendinous junctions. So it decreased the metabolic load. They found that the patients were up and active more, so it decreased weight gain for them. They had better overall health. Again, if we're looking at comorbidities, all of these pieces are important. Looking at the interface between the socket and the residual limb, there are some more advances that are coming out to look at improving stability for the individual inside the socket. They're looking at sensors on the right bottom image here that are applied to sense the temperature, pressure, and moisture so that the individual is aware if they're at a potential risk for a skin breakdown in that residual limb. They're also looking at sensors that will give the individual some kind of vibration or feedback to let them know a better sense of the position of the prosthetic limb and foot to allow for better stability with gait. For the upper extremity prosthesis, this is amazing. They are trying to use different types of sensors. On the left-hand image here, this is the prosthetic hand trying to grab a grape. And in 2014, they started implanting these electrodes. So what happens is, this is the system. It's amazing. So the individual with the prosthetic hand on the right here, let's say they grab a grape. So there's a sensor in there that senses the amount of pressure that's being applied to the grape. Inside the individual's residual extremity, they have a nerve stimulator that's implanted next to a proximal nerve that's intact. So the signal goes from the sensors to the proximal nerve that's intact. That intact nervous system now brings the signal up to the brain. The individual says the pressure, it's kind of like a pulse. So they can sense, in a way, how hard they're squeezing the grape. They send the impulses back down to an intact motor nerve that will then control the prosthetic hand to allow them to sense the pressure that they're holding the grape with. It's amazing what they're able to start integrating for this population. A smart cane is another device that they are utilizing for individuals to get some feedback on how much they're weight bearing through the cane. We know that a cane is primarily utilized for stability and balance. What they found in individuals with osteoarthritis, that if they put the appropriate amount of pressure on the cane, it'll significantly decrease the impact on the lower extremity. in order to diminish the pain and stress on the joint. So they're trying to come up with a cane that gives a sensor or a vibration when the individual puts the appropriate amount of body weight through the cane, because even if they estimate about 10 to 20% of their body weight, it significantly decreases the joint impact force, so that can preserve that joint for the individual. So those are some of the advances that we're looking at in our populations with spinal cord injury. When we look at potential spinal cord injuries that may occur in the combat zone, this is a challenge to manage when the individual has the body armor in place that they often need to leave in place because they are still under fire. However, it can cause malalignment. We know in the civilian management of spinal cord injury, immobilization and stabilization is the first step. That may not be possible if the individual is not in a safe area. So they need to find a way to stabilize this patient during providing care under fire, and also through the extraction process through those different levels of care that we discussed. What they're starting to look at is, rather than physical immobilization, if they are unable to do that, they're starting to analyze the utilization of hemodynamic stabilization. So research is showing that if they can maintain perfusion to the spinal cord, if they increase the oxygen perfusion, and if they maintain the arterial pressure over 80 millimeters of mercury, it seems to be beneficial in controlling that spinal shock, and can be utilized as a measure if they can't physically stabilize the individual. Other care that's provided to the individual who has a spinal cord injury is similar to what we see in the civilian sector. So I'm going to move forward to the rehab component and some advances that are occurring. What they're finding with the spinal cord injury research is advanced lower extremity neuroprostheses. In 2015, it was a combination of work between the Case Western Reserve and the VA. They completed a 10-year study where they implanted electrodes into the muscles of the trunk and the lower extremity for the individual. And then they wore this external stimulator where they could push a button and perform sit to stand. So it allows them to have weight bearing to diminish osteoporosis. It increases circulatory capacity, respiratory capacity, also helps with the weight bearing and managing tone, and overall improves function. So it's a brace-free way for the individual to stand. They took this a step further, and on the bottom right, this individual, they're able to use computer models to program the device in order to stimulate the muscles to replicate gait for the individual without that volitional effort, because they have the spinal cord injury. So we'll continue to start seeing different types of advances for this population in the use of implanted stimulation for mobility. If we think of the individual who has a higher level spinal cord injury, so they have a lower functional status where standing and ambulation may not be an option. For the individual who does not have full thoracic control, we're looking at concern over their respiratory capacity. And what they're utilizing is implantation again of those electrodes to stimulate the thoracic muscles and the upper extremity scapular stabilizers. The individual here in the first image on the right, he's leaning forward and trying to sit up with the volitional control he has. And even though he's trying to use momentum from his upper extremity in his head, he's having difficulty sitting up. On the lower image here, he has the electrodes implanted and they're stimulating. And look at the improvement in his head and neck control. Look at that expansion that's occurring anteriorly of the thoracic cavity as well as the head and neck. And the improvements here is that this can help improve not only alignment, but it's going to increase respiratory status, have that improved vital capacity for even if it's bed mobility or wheelchair control. It'll decrease the risk of respiratory infections. Even if the individual can just reposition a little bit better, it can decrease decubitus management and maybe in some patients provide enough proximal stability so if it's an incomplete injury, maybe they have some more use of their upper extremity. Again, thinking that this population may have concurrent respiratory compromise because of their different exposures, it's important for them to consider this. BrainGate is an amazing advancement. This teeny tiny little electrode, it's like the fraction of the size of a dime. What they did in 2011, they implanted the brain into the brain, this small little computer microchip type. It was a combination of research between Brown University and the VA, and the individual that had this implanted into their brain, they were actually able to control a cursor on a computer in order to match targets. And they were able to do this for 1,000 days. Now, that doesn't sound like much, but that is the start. This is how research happens. Their eventual hope is that with these implants in the brain, that they'll eventually connect to robotic arms, that then the individual with the spinal cord injury will be able to control. So they have like a robotic limb over their natural limb, and they can control it with their brain in order to elicit functional movement. And eventually the applications could be patients with ALS, brainstem stroke, not only spinal cord injury. Looking at mobility for patients and what's available currently, this is the ReWalk system. The two individuals here, you can see that they have these harnesses and straps around their body, and then coming down their lower extremities, they have a bracing system on. And what this system does, it is a robotic exoskeleton. And as I mentioned, in 2014, it did become available in the US, and the VA did start funding this. Most individuals, the first day they put this on, they say they can get up and actually stand. And at minimum, some of them are able to actually take a few steps. And what the research is showing is that this robotic exoskeleton allows advancement of the limbs for ambulation. Ambulation is important, but think of the weight bearing and the benefits of that. Go beyond that. Think the population we're specifically talking about today is multi-system involvement. This is going to increase their mobility, increase their respiratory function. They found improved bowel and bladder function for the patients, decrease in their body fat tissue, decrease in diabetes symptoms. So there were many other benefits in addition to just being vertical and the ambulation component for the population to improve that cardiometabolic health and holistically treat the patient in addition to improving their function and their engagement. Traumatic brain injury is the next diagnosis we'll take a look at. Unfortunately, this has been determined to be the signature injury of the current post 9/11 conflicts. They're saying that about 20 to 30% of all casualties from the current conflicts are related to brain injury. There are about almost 86 million mild head injuries. This is significant. Sorry, not 86 million, I apologize. 86% of the injuries that are occurring are mild head injuries. And we're seeing actually an increase in the moderate head injuries that our veterans are sustaining. Now, the majority they're finding are occurring in the Army, with lesser percentages in the Navy, the Air Force, as well as the Marines. Understanding the mechanism of these injuries is important because it's slightly different and more complicated than our civilian population who sustains traumatic brain injury. And by understanding the mechanism, you'll again have a deeper recognition of why we need to assess so many different body systems. What happens when there is a blast injury, that altered pressure that occurs from the blast is going to impact the brain that is in a solid cavity of the skull. So there's only so much space. What they're finding is from the pressure of the blast injury that it is actually creating an alteration in the cerebral blood flow, that it is impairing the synaptic transmission because we're getting shearing of the axons in the brain. Some research said there's air embolisms that form, microhemorrhages that occurs, and actually a change in the neurons in the brain from that blast injury that relates to the damage. On top of that, because the individual is propelled and shifted, we also have a coup counter coup injury. So the brain is shifted forward and then back in the cranium. So this individual here has an injury on one side of the brain, and then when the brain shifts back and impacts the opposite part of the skull, they have a counter coup injury. So we see multiple regions of involvement. Those are closed head injuries. We're also seeing damage occurring from penetrating trauma and ballistic trauma that occurs, even though the individual in the right here, they have their helmet in place. These blasts are often coming up from down below, so we can still have penetration from different areas that will go into the brain. Unfortunately, what happens as these fragments and projectiles go through the brain, they create like a negative pressure as they're going through. And in their wake, we can see it here. If we look at the left-hand image in this area, I'll go parallel to it. You could almost see like striping here. They're black lines. That is a scan showing those fragments that went through. They cause a cavitation, like a contraction and expansion of the tissue in that negative vacuum left behind when the fragment goes through. This is stretching all those neural support structures in addition to damaging the paths in the brain. So that high velocity vacuum causes extensive damage to the tissues and the different neuronal structures in the individual. Previously, what they would do is go in and actually try to remove the fragments and debride and clean out. Now they're saying they don't do that. They're more so just allowing the brain to heal. So this presentation is going to be different because it's more vast trauma inside the brain. When we look at medical management of this population, managing the intracranial pressure is important, particularly in the closed head injury, because if there's increase in that pressure in the brain, it can cause more compression and damage to the neural structures. They also found that as intracranial pressure is rising in that restricted space, that it restricts the vasculature, leading to more tissue hypoxia. They've seen temperature dysregulation, mitochondrial damage starts to occur, as well as that hypoperfusion, and then the body reacts with inflammation. So what they really need to do are supportive measures to try and manage this vascular compromise, and they're trying to keep the blood pressure below 190, below 90, and the intracranial pressure below 25 to limit that extensive damage. Because there have been so many brain injuries, the Department of Defense have actually developed their own definitions of the brain injuries that our military personnel are experiencing. The penetrating and severe injuries are at the high end of the scale. The mild concussions are what we are seeing an increased incidence of. And the mild and the moderate are where we're not really seeing CT changes, and these are the ones that they felt they needed to catch more because of the implication of repeated mild traumatic brain injury or moderate, the cumulative damage that occurs for the individual. So what they're looking in terms of diagnosis, because tests may not show the damage is more of a descriptor, looking at what the individual symptoms are and signs. So a moderate traumatic brain injury, the individual is going to maybe have a loss of consciousness of more than 30 minutes, but less than 24 hours. And then particularly look at the memory loss piece as an indicator of the severity of the brain injury, that if the memory loss is greater than 24 hours, but less than 7 days, they're falling into that moderate definition. The clinical presentation, the Glasgow Coma Scale, is still utilized to assess the level of consciousness through how well the eyes can open, the best verbal response, as well as the best motor response. If you are able to look back at the patient's record and know the Glasgow Coma Scale rating, in addition to the TBI case definition, it'll give you more perspective on the rehab. A mild traumatic brain injury is a 13 or greater grade. So a better grade is a less severe injury on the Glasgow Coma Scale. The clinical presentation for individuals with the mild traumatic brain injury, the sequela is broad, it is transient. They may have brief amnesia that occurs, maybe for a day, challenges with cognitive processing, problem solving that's interfering with their function, headaches, dizziness, maybe altered smell and other vision, other sensations. And what's important is the military is recognizing that during this time, the brain needs to heal. That individual cannot go back out into combat. They really need to rest and allow the brain to heal. And then it needs to be a progressive return to function. It's not like some orthopedic injuries where there's a predictable healing pattern, and after X amount of time or a particular scan, we know that they're okay to go back and function. With the brain, it's a more complicated process. And what they're finding is it really comes down to symptom assessment and exposing the individual to progressive levels of challenge physically and cognitively to make sure they're ready to handle it and the brain has sufficiently healed. So what the VA has developed, or the DoD, I should say, has a return to activity progression. This is a huge document. It is included in the references, and it's a great document that really dictates the progression that a patient should go through following that mild traumatic brain injury to return to active duty. And what happens is, again, we see these things develop with the VA, and then they expand to the civilian population. To give you an idea, stage 1, the individual is resting. At this point in time, they're just allowing healing to occur. When we go to stage 2, The individual is still in likely the combat area, but they've been removed from combat. They are in the recovery process. They're going to start letting them have some light activity. They might allow them just to wear their uniform, which, remember, think their uniform includes a lot of standard equipment, so that is physically a challenge that requires metabolic expenditure for the individual. They may have them go outside, see if they're able to just regulate their temperature with the temperature changes. Engage in some light reading for cognitive stimulation, maybe cards, a light ball toss, to see if they're able to execute and plan those activities. If the individual is asymptomatic, so they have no additional symptoms, their resting blood pressure remains below 140/90, heart rate below 100 for 24 hours with a set stage of activity, then they're allowed to progress. If not, they have to stay at that stage and level of activity until they reach those hallmarks. Stage 3 progression, the individual is going to slowly increase the cognitive demands. So they might be doing a routine vehicle maintenance check, see if they can execute that. They might allow them to be a passenger in a car, which does require cognitive awareness and problem solving and engaging, because think of where they are. They're not just here on the highway. And then they're going to slowly increase their physical activity level and the amount of time they're allowed to participate in activities. By stage 4, if this individual is permitted to maybe do weapon simulations with video games to increase their cognitive and physical activity. And then by stage 5, we're moving to more intense activity. They can start going on some patrols and see if they're ready to resume their normal type of activity. So it's a slow, specific progression. And this is important because we don't want the individual to fall into a post-concussive syndrome. And post-concussive syndrome is where the individual has residual deficits of dizziness, impaired concentration, fatigue, photosensitivity. I want you to think about your reserve members who maybe are going out on the weekends. They're participating in training sessions. They may have a potential injury and they're coming back to us to resume their normal course of therapy for maybe a completely different diagnosis. But if they did sustain some type of trauma, be aware of that. Also, if we're seeing our veterans more than 3 months out when their symptoms should have already resolved from their mild traumatic brain injury, if they're still having these symptoms, then we're concerned that they might be moving into a post-concussive type of syndrome. Rehabilitation for the individual following a traumatic brain injury of any type is going to follow the typical strategies that we are already utilizing, with the severity and the intensity of rehab matching. We're finding that the goal is to improve the cognitive as well as the physical function. We need to also address mood and behavior for the individual to allow them to reintegrate into civilian life. The VA does have specific brain injury rehab units that pull together looking at all the different systems for the individual. Long-term during rehab, monitoring post-concussion is important. There are a couple of different apps that allow for this monitoring post-concussion. The individual may not be aware of small changes in their mood or their cognitive functioning, so the app is going to allow them to track that. It'll give them relaxation exercises, and then it also has resources to refer the individual out to. And again, what they're finding with a lot of these apps is just utilizing it helps improve awareness, empowerment, and improves the symptoms for the individual. In terms of concussion, the app and self-monitoring is not going to fix their impairments, but sometimes by having a self-awareness, they can better manage their reaction to stress or learn relaxation tools to assist them. And because we're engaging with our patients, we might be the one to catch these fluctuations and make these additional suggestions and referrals. Considering the headaches that the individual is presenting with, post-traumatic headaches may be related to the injury that they sustained. Many will be of cervicogenic origin if they had trauma to the cervical region, but the individual may also have pre-existing migraines that have become aggravated, or maybe they're tension headaches that are developing from the stress, or the headache is part of the post-concussive syndrome from the mild traumatic brain injury. So all of this has to be discerned in your assessment of the patient. When we look at managing the sensory impairments of individuals following traumatic brain injury, we can't forget that visual system. The oculomotor pathway, they say it's in what's called a vulnerable part of the brain, and it's in the brainstem region with vast connections throughout. So it is going to be significantly compromised in some individuals who sustain that traumatic brain injury. There was a 2015 study looking at the veterans, and they found that in many of the individuals that all the tests and assessment for vision, they tested out clinically within normal limits, but practically the individual had difficulty using their vision for functional tasks. So that's something to look at, how it's impacting their balance. It can then impact, social interactions, work life, and they're actually finding it can exacerbate symptoms of PTSD, some of these sensory impairments from the traumatic brain injury. Another consideration I want you to be aware of is the neuroendocrine implication of individuals who sustain a traumatic brain injury. Again, our patients talk to us and things may come up in conversation that we need to mental note and put the pieces of the together. If our female veterans who may have been exposed to an explosion or potential traumatic brain injury is in their past, we have to recognize that we have our pituitary gland located deep-seated in our brain. Our hypothalamus plays a role in also managing our hormones. And what they're finding is that the brain injury may lead to altered functioning of the hypothalamus and the pituitary and a dysregulation of hormones, specifically the thyroid, the gonadotropic hormones, growth hormones, which impact bone and muscle. So if your female patients have excessive fatigue, decreased muscle mass, increased body fat, maybe amenorrhea, decreased menstrual cycle, blood pressure is running low, you might want to consider referring them to a neuroendocrinologist to see if potentially something is off in their endocrine system from that mild traumatic brain injury. Where the research is heading with this population is looking at, from the mechanism of injury of the explosions, the additional areas of the brain that may be impacted. And what they're finding from rat studies is that there's significant cerebellar trauma that also occurs from repeated blast exposures. The University of Washington was replicating blast exposures and analyzing the cerebellum in rats, and they found that there's a slight rupture to that blood-brain barrier in that region with loss of neurons, and they're finding that it actually is leading to challenges with the cerebellar functioning. So the individual assessments that you might want to include are your cerebellar dysmetria, dysarthrokinesia, balance assessment, just to see if potentially there is an impairment to the cerebellum, which would require different rehabilitation techniques. And then CTE, chronic traumatic encephalopathy, we've heard a lot about with our athletes and sports, but our veterans with traumatic brain injury, we need to be aware of. In 2008, the Brain Bank was a collection of, started for that postmortem collection of brains. It's a combination, the DOD, the VA, the sports industry, and they're looking at in veterans as well as athletes that sustain repetitive traumatic brain injuries, that there's actually a change in that brain functioning. And they look for a tau marker, there are tau proteins that start to develop. And when they start to see is that as that spreads throughout the brain, it causes clumping and deterioration of the brain cells. They haven't really fully understood it, but what they're finding is an increase in Alzheimer's-like symptoms, a decrease in judgment, dementia. So these are concerns, which is why we need to recognize the mild traumatic brain injury, decrease exposure, allow healing before there's another potential exposure so that we don't have these long-term implications. They're also finding a link between Alzheimer's disease in our veterans population who have a history of mild traumatic brain injury or higher. That it somehow it seems to be predisposing them to a traumatic dementia this has a long-term consequence as we look at our veteran population who is aging. So be aware that if you're seeing those problem-solving challenges and it's not connected to their diagnosis, it may warrant greater investigation. And they're also finding that brain aging is changing in individuals who have had the traumatic brain injuries. When they looked at veterans who were within 100-foot blast radius from an explosion versus those who were not, they found that the myelin sheath on the axons, that its ability to conduct impulses was impaired, that there's premature aging and deterioration of it. And this again is causing the brain to, age more rapidly, where we're seeing cognitive impairments younger in these individuals. Post-traumatic stress disorder is a diagnosis that many of our veterans may present with. Mental health is of a significant concern. They're looking at both biological as well as behavioral risk factors in our service members that leads to the development of this PTSD. The estimate is that in the post 9/11 conflicts, somewhere between 10 and 18% of veterans will present with this condition where they have physical symptoms as well as mental reaction to the experiences that they have been through. Psychological first aid is something that's being employed earlier on to help manage patients sooner who have been exposed to a multitude of different traumatic events. So hopefully it does not develop into a PTSD. So I did include a couple of slides related to psychological first aid. Unfortunately, in today's age, we do see a lot of different types of disasters that are occurring. So I included a couple of slides that might be helpful to you just as an FYI. Looking specifically at PTSD, there is a progression of this condition. If the individual has intact coping strategies, they will manage the trauma and be able to continue to function. Unfortunately, what they're finding is that over 90% of our veterans have at least 4 traumatic events that they've been exposed to. Now, evidently what we would consider traumatic and what they do is different because of the work that they're in, because I would think it would be much more than that. But in terms of what's being tracked in the research, those significant events that could lead to the development of PTSD. Some individuals are able to manage it, others are not over a prolonged period of time, looking greater than 3 months out. If they still have those feelings of fear, helplessness, maybe emotional inappropriate reactions, fatigue, they might be moving into PTSD. The symptoms the individual will specifically present with is going to have negative changes to their mood as well as their cognition. They may also present with certain physical symptoms because of the PTSD. The physical symptoms that someone presents with PTSD could be chronic pain, migraines, vague GI, cardiovascular complaints. They may have difficulty with attention, maybe emotional guilt, helplessness. They may be more irritable. And the way that these symptoms develop in the individual and present, it needs to be distinguished from maybe that traumatic brain injury. So this is where working closely with the different physicians and other healthcare providers is important. The symptom clusters that the individual presents with, the one that many of us think of are going to be the intrusive memories, those flashbacks that the individual has of something that happened before. Maybe we're going to see them avoiding activities and becoming more detached from their family and friends. And then we're going to see that increased awareness and arousal from that individual, which could present itself as tachycardia, diaphoresis, and tremors. When we're screening individuals for the presence of post-traumatic stress disorder, the mental health provider uses several different tools in order to screen the individual. They say that there's no one tool that is best. These are not necessarily tools that we would be utilizing in the clinic to assess these patients. However, I do include the evaluation of lifetime stressors, the life event skill, and the combat exposure scale. They're tools that will be utilized by the mental health provider. So if you are able to know their scores on those different assessment tools, it will give you some input on the severity of their PTSD so you can work more closely with that healthcare provider. Looking at the evaluation of lifetime stressors tool, this is going to ask them if they remember the event. It is going to look at the frequency and duration of different events that they may have experienced, and the healthcare provider will use this just to see if they're at risk for developing PTSD or they have an event that may have triggered it in their life. The LEC-5, this is a self-report measure. It has good validity. Looking at, again, at exposure to traumatic events. It's going to ask if it's part of their job or were they a witness to the event to see if they're at risk for developing those PTSD symptoms. And then the combat exposure scale. This is going to be more specific for wartime type of stressors to see if there are triggers for the individual. It's going to ask what type of duty they had. Was it, dangerous type of duty? Where there's firing from enemy rounds during their exposures? And then they're going to rate how often they've been exposed to those different events. So those are tools that the healthcare providers might use, but if you can glean that information, it will help you know their diagnosis. Management of individuals with PTSD is going to be multifaceted. You'll be working with other mental health providers, be using exposure and imagery. They use cognitive restructuring to try and help the individual evaluate the accuracy of their belief and their fear and what they're concerned about to see if it really is a true danger or not. And they're going to combine that with a lot of self-monitoring and cognitive therapy to kind of challenge their beliefs. So you might want to find out what those specific strategies are so you can utilize that phrasing during your rehab. When we're working with this population, we need to be aware of potential triggers that the individual may present with. And first, we need to get a sense of what those might be for the individual. To accomplish that, you might want to incorporate into your screening of patients the primary care PTSD screening tool. So these are several specific questions that you can utilize on intake with your patient that can kind of start the conversation to see if they have potential PTSD. Now, I want you to be aware that we need to think of this critically in terms of their answers, that if the individual is saying that they are having difficulty in social situations, is that because of their mental health or because of a physical impairment, which would be different goals. Some follow-up questions that you might ask your patient are things like, I noticed from your answers that you're experiencing some symptoms of stress. How is that affecting your life? I understand that nightmares are an upsetting event. So we want to ask them about their nightmares because maybe the nightmare is about a social situation. Maybe it's not PTSD for them. When we're managing our interactions with individuals who present with PTSD, think about the physical space. If they're feeling confined and restricted, don't place them in that part of the clinic. Make sure that they may have an area where they can leave and have more space. Be aware of your touch, that if you're doing massage or physical interventions, they may not be comfortable with that. So you really have to get a sense of what's comfortable for that patient. Also consider your responses to the patient. Sometimes we don't know what to say, so there are some examples here. Maybe, I'm sorry you've had such terrible nightmares. Thank you for sharing your symptoms with me, but don't ask for a detailed account of things. When we have an individual who is undergoing a flashback, sometimes we don't know how to respond to them, and I could think back to a specific patient who every time in the hospital, the meal cart would come around at night. It had a bum wheel, thump, 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 thump. It would create a flashback for him. So I'm like, why can't they just go down a different hallway? Why do they always have to go down his? But how do we react? What do we do when the patient is experiencing that flashback? Here are some suggestions for you. You're going to watch noises that may be triggers, but if something is triggered in the individual, the key here, they say, is really to remind the patient that they are in a safe place, that they are safe, they are here. You want to do things to kind of bring them back into the current reality. Maybe see if they can drink a glass of water. If you can have them, feel their clothes, feel the material, give them a warm washcloth on their face, something to try and pull them back into the here and now, in addition to letting them know that they are safe. When we look at the impact of all these different diagnoses, they're starting to find clusters that have a relationship. And what they've recognized is that these individuals presenting with PTSD and traumatic brain injury also seem to be presenting with chronic pain. And they call this post-deployment multi-symptom disorder. And what they're finding is that they have diffuse somatic complaints, they have cognitive impairment, attention deficits, emotional dysregulation, potentially insomnia. So it affects mood as well as physical function. And we need to kind of tease everything out to most effectively manage these patients. When we look at assessing pain in any of our patients, that we use that typical pain scale in a 0, no pain, 10, tell me, is your pain most severe? We ask where the pain is, and we try to get a sense of it. What we need to do is recognize that pain does have a mental component to it. And in this population, they have been in conditions that we can't even imagine. So pain that maybe here in civilian life would be intolerable to them may not even be something they're going to give attention to. But now we're back in civilian life and trying to rehab them. So think of that piece that their recognition of pain may actually be different. So when we look at chronic pain in this population, we're considering the consequences are going to go beyond just the physical pain that the individual is looking at. The DoD and the VA is saying that we need to consider that having pain can lead to other physical stressors for the patient, and there's often this connection of symptoms of not only the emotional stress, but we see sleep disturbance, and then combine that with the residual traumatic brain injury symptoms. It's leading to this increased chronic pain pattern that then impairs function and activity for the individuals. Screening tools that we utilize to assess the pain, we're going to use our typical musculoskeletal assessments, look at what's triggering the pain. However, the VA has come up with their own pain assessment tool, visual analog scale, to give it a little bit more of a perspective, like I said, because they may not think of pain in the same way. So on a pain scale, 1 is going to be I hardly noticed the pain, not how did you mentally interpret it or what did you do with it. It's saying 1 is I hardly noticed, 5 is it's hard to ignore, it caused me to avoid activities, and 8 is it's awful, I can't do anything. So it gives more context to those numbers to help us look at that fear avoidance cycle that is an important role in chronic pain. Then we have follow-up questions. So once they recognize that pain, we know what region of the body it's in, it gives us the number. Now we're going to say, okay, in the past 24 hours, we want to know, how did that pain impact your activity, your sleep, your mood, and your stress? So we're looking more holistically at the pain the individual is experiencing so that we can best target it with our therapy interventions and then outside referrals. That pain management is multifaceted. There's the pharmacological management. They're trying to decrease the use of the opioids. They're looking to break that cycle for most patients and use different interventions, not just those opioids, because of that significant risk of dependence, addiction, and death. We can play a role in monitoring patients to see if their opioid use is too high. They may start presenting with complications from increased use of the opioids, and we can work with the physician if we start seeing that respiratory depression with alterations in breathing, mental status changes, and then sleep apnea. If they are on opioid medication and they have loud snoring, morning headaches, that pause in breathing, maybe short-term memory loss because that apnea's difficulty breathing is leading to less sleep. This may be indications that you need to refer them back to the physician to see if their pain medication dosage is appropriate. Non-pharmacologic management is where we can play a significant role in managing the pain, maybe biofeedback, teaching them how to calm down certain muscles and relax, or even just mentally recognize that mental stress causes physical muscle tightness. Use some biofeedback, yoga, meditation. Looking at individuals, there was a study in 2016 where they looked at veterans who had post-traumatic stress disorder. It was a reasonable cohort, around 230. They had pain and they had them participate in an exercise program within their tolerance. They actually found that those individuals, even if they participated in low-level exercise, had increased cardiovascular status, which makes sense, but extending that out, they had increased socialization, decreased PTSD symptoms, and then they actually had better interpretation of their pain, because we need to train these individuals how to interpret their body responses. When they are overseas or they're in a threatening environment, the heart rate is going to go up. The blood pressure is going to increase as a natural response, except they're not tending to that because they're involved in their operation or whatever they're participating in. Now we need to teach them what's a normal response to activity. It's okay if your heart rate increases. That's a response to exercise. If you stop and slow down, it'll come down. That doesn't mean something bad is happening to your body. So we may need to retrain them in these pain, fear avoidance patterns. Cognitive behavioral therapy, our mental health clinicians will participate in challenging those automatic beliefs that the patient may have to increase their mobility and activity and their mental processing of their pain. Patients may also present with non-somatic disorders. So we mentioned spinal cord injury, head injury, amputation. In addition, the individuals may present with as well as anxiety, drug use, and sleep disturbance that we need to be aware of. Assessing anxiety in our patients, there are different scales that we can utilize. The Beck Anxiety Inventory, it's a quick 5 to 10 minute assessment that's utilized. This is not looking at depression. We do not diagnose that. We do not diagnose anxiety either. However, we may want to have a sense of our patient's anxiety level combined with their other diagnoses so we can make the best clinical decisions. So they're going to have simple descriptors that then they have to rank these different items based on how much it's going to bother them. So is it, very unpleasant, or I couldn't stand it at all? Looking at these different activities. And then it gives us a ranking where 0 to 7 would be minimal anxiety, and then 26 to 63 is going to indicate a higher anxiety level. This particular assessment, when we look at the population with polytrauma, it has many different parts to the assessment and questions that it'll answer. So they'll answer questions about their fear. So was your heart pounding and you were unable to relax? Are you having numbness and unsteadiness? Look at the neuropsychological piece. Are you, looking at panic? Are you having fear? Are you feeling shaky and trembling? Is your face flushed? So it's looking at all these different physical responses for the individual in terms of what's happening in their civilian life now. However, what we consider stressful and aggravating is nothing compared to what they went through, that they've had to learn how to deal with. So the answers may not really fit appropriately. What they found in the research looking at veterans that have different comorbidities, concussions, and head injury is specifically looking at the item inventory on safety threat on the back gives the best indicator as to their anxiety level, because that's the one that seems to give the most information on truly how much anxiety they're experiencing. To manage with all these different symptoms, as well as the life changes that they are going through, individuals are going to utilize many measures. And unfortunately, they found that about 50% of individuals who've had at least one mild traumatic brain injury or higher are going to have alcohol misuse. That individuals who also have PTSD and a mild traumatic brain injury, about 40% of them have alcohol misuse. Things you might want to listen for in your conversation to see if this might be an issue for the patient is, I don't drink every day. I gave it up for 3 weeks last year. Not something we diagnose, but our patients talk. We hear them talking to other patients. We put the dots together with what we smell, how they're acting, to see if there needs to be an outside referral. Particularly with our female veterans, this is a growing population that has additional needs to be addressed. A little history on that starting in 2015, females are being included in operations that they historically were not involved in, that they are becoming leads in the infantry. They're working on more reconnaissance, special operations. So they're being exposed to greater injury and stress than they historically were. So the VA has recognized that women respond differently emotionally than men do. And in rehabilitation, there needs to be a greater consideration of this. Females are actually the fastest growing veterans population. So now they actually have women's veteran centers and coordinators. And in some of the research, what they found is that to decrease PTSD symptoms in the female population, that having friends, family, and social support seem to play a significant role in their rehabilitation, and those pieces contributed to less PTSD symptoms compared to their male counterparts. Sleep disturbance. A lot of what we talked about can contribute to sleep disturbance, whether it's an orthopedic injury because they're unable to position and get comfortable, maybe they have altered tone from the head injury or the spinal cord injury, or it's the respiratory compromise, the PTSD, the chronic pain. There are so many reasons that there might be altered sleep. Additionally, consider that when individuals go out, maybe they go into the reserves or they go on different training, their sleep-wake cycles are being disrupted during that time period, and now they're coming back into civilian life. All of this can implicate them to have sleep disturbance ongoing. The reason this is such a concern is that we know that our bodies need to sleep in order for it to heal and recover. And when they specifically look at individuals who have the mild traumatic brain injury related to post-concussion, they're finding that the neuroremodeling that should take place when we're asleep and having rest, it can't happen. And they're recognizing that particularly the hypothalamus following the mild traumatic brain injury, that it's decreasing its secretion of the neuropeptide that regulates our sleep. It takes it about 6 months to return to normal. The pineal gland has altered melatonin, and this is leading to a greater sleep disturbance. This may contribute to increased pain in the individual because they're not processing as well, they're overtired, they're irritated. The lack of sleep leads to impaired cognition, irritability, greater PTSD symptoms, and this becomes a loop for the individual. Sleep assessment is something that you might want to include in your intake for your patients. You're going to look at some simple tools. One of them is called a Pittsburgh Sleep Quality Index, and this is going to ask the patient to look at their sleep habits in the past month. It's a little complicated to score, but it does have an online way to assist you with that. It asks them things like, do you wake up in the middle of the night? And that question, I will tell you, you kind of need to follow up on, because why did they wake up during the night? Did they have to go to the bathroom? Maybe because they have kidney disease setting in from that embedded fragment, or they had pelvic trauma from the blast injury, and now they're getting older and genitourinary compromise. So it's really not a PTSD or a pain issue, it's a renal issue. Are they having difficulty breathing because of respiratory compromise? Is it the tone that increased, not allowing them to be comfortable? So when you look at the sleep disturbance, you can use the score to tell you that there's an impairment in sleep, and then you have to take it a step further to see, well, what's impairing them and what are my opportunities to set goals to address those challenges or make outside referrals. Some basics that we can just look at related to sleep hygiene are some cues for our patients to, only use the bed to sleep. Don't be eating in there, hanging out in there. Decrease the use of stimulants leading up to, they say, at least 4 hours or 6 hours before bedtime. Particularly limiting naps is important. To not take naps after 4 p.m. because then that can inhibit the individual to sleep, removing electronics. So some different basic ideas that someone can try here to empower them and see if it makes improvements, in addition to looking at your positioning for the patient, your free environment to get to the bathroom if that's waking them up. So consider sleep hygiene as some patient education. In all of this, we cannot forget ourselves. If we do not keep ourselves mentally and physically functioning appropriately, we are not there to assist our patients. And I don't know if you've ever heard of compassion fatigue. This can happen in our profession, that if you maybe over time in working with individuals who have many impairments, we are giving our all to all of our patients, not just our veterans, that sometimes there's that tension and that preoccupation with everything they're going through, and we internalize it for ourselves. So it almost creates like a secondary trauma that we could potentially be experiencing that can lead to physical, emotional exhaustion. That if you start finding clinicians who are losing that ability to emphasize, they're finding decreased fulfillment from their job, they are depersonalizing their patients, you might want to consider they're going through a little bit of compassion fatigue. There is an app where we can encourage provider resilience, is what it's called, to self-assess ourselves. There's some informational videos as well as tools to give us rest breaks to keep ourselves in a good mental place so that we can support our population during rehab. In conclusion, we're going to obviously remember everything that this population has done for us, and my hope today was to give you some different aspects to consider in rehabilitation so that we can holistically treat this population to maximize their abilities to reintegrate into civilian life and have a fulfilling life for themselves for everything that they have done for us. The question is, would a white noise machine that is used for small children be considered damaging to their hearing over time? That's a great question. I'll be honest, I don't know. I've never looked into that. The way that I looked at hearing for this particular course was related to the exposures that the military has been tracking. And what they look at is the decibel level and what is considered safe. And at different decibel levels, different length of time exposures make it safe or unsafe if it's a lower decibel. Question is, any risk of secondary exposure to therapy or hospital staff from depleted uranium in veterans? Um, I didn't come across anything related to that. What the VA and the World Health Organization is saying from the data that I was able to pull at this point in time is more that over time, it is the release of the chemicals into the circulatory system of the individual, and then either it has toxicity in the different systems or the strain on the kidneys from trying to flush it out can lead to kidney damage. They didn't mention secondary exposure because it seems at this point it's more the long-term exposure to that fragment being embedded. Again, they haven't had time to really look at long-term exposure and risk factors yet. They're still trying to gain information on that and complete that research. So my thought would be on that, if someone does have a fragment implanted, or let's say something they were to bring in something that was maybe expelled from their body system, or they were able to retrieve superficially, I would obviously handle that with universal precautions and then definitely contact the VA surveillance team on how to manage that appropriately and what the next step is. And related to vibration, just in general, the longer you're in this profession, the more we see that so many things over time, we tend to be learning more about the long-term impact of it and potential negative consequences. And vibration is something that's really emerging in all of therapy and workplace injuries to be aware of and look at minimizing because of the long-term consequences on the musculoskeletal system. Then on the flip side, there are ways to appropriate utilize certain types of vibration to decrease, let's say, tone or other pathologies that someone may present with or symptomatology. So vibration is a big subject. All excellent questions coming up as now we think about hearing and exposures, broadening it to other populations we may be working with. It's a good question, and it's an opportunity for us as clinicians, if something seems off when we're doing our assessments, that maybe that referral is necessary to the EMT or an audiologist to have a hearing assessment. And that's my hope with these topics, just to broaden our perspective and have us look at our patients differently, so we're providing the highest level comprehensive care as possible. The question is, how long does the bone implant last, and does it potentially loosen? Those are great questions. The research is still emerging on that technology, so I haven't fully looked at that yet. For this course, I just went up to the point that they are starting to utilize it. So I guess we'll see that information emerging in terms of long-term implications with loosening. One of the questions is, any research in PTSD and medical marijuana? That's actually an area that I have not looked into yet, the medical marijuana. I think the research is still emerging on that in many different areas, so that is not something I've touched yet. The question is all this new technology is very expensive, I assume? Are all amputees eligible for these? Um, it is going to depend on whether they're going through the VA. I don't know exactly what the criteria are to be approved. As I mentioned earlier, a lot of individuals don't even go through the VA for the benefits. They're going through their private insurance. So then that would become a factor also. I can't speak specifically to the coverage, but I would think it's definitely an opportunity to check for the individual. Are they maximizing their access to all the different benefits that they may be eligible for as we look to some of these advances? So maybe to make those referrals back to the VA to see if they're accessing all the services that are available to them in addition to their private insurance. And some of this technology is still in the research phases, that it may not be available to the general population at this point. Some things may be parts of medical trials that are going on. So that may be another avenue to explore, to see about having your patients potentially become a part of those opportunities moving forward. So they're really trying to enhance the technology to allow individuals more mobility. What is currently available is called Rewalk, and this is based on Israeli technology. It was, I think, 2014 is when it started becoming available for sale in the United States. Exoskeleton that is going to allow them to initiate gait, and this exoskeleton is going to allow them to ambulate. The research says that individuals, the first day they put this on with the bracing and the electrodes and the components, that it will allow them to ambulate that first day that they're up. They've seen significant improvements in the study participants, not only in decrease in the diabetes symptoms because of the increased cardiovascular status and improved metabolism. They're actually finding decreased fat tissue, so again, promoting cardiovascular health. But they saw things like improved bowel function for the individuals. They are, again, upright and participating more at a different level of activity. So significant improvements for individuals, and this is something that is currently available, and the research says that the VA is funding this. They're still utilizing the Glasgow Coma Scale in order to rate the loss of consciousness, or the level of consciousness, sorry, with the brain injury. This is going to look at the best eye-opening, verbal response, and motor response for the individual. A score that is lower indicates a more severe brain injury. And again, if you are part of that veterans network, you would have access to all of this early medical information that will give you more insight to better rehabilitate your patient. Individuals with mild traumatic brain injury may present with headaches. That is a indicator of the concussion persisting in its symptoms, or it could be an exacerbation of migraines that they had previously. And if they sustained a physical trauma, it may also be a cervicogenic headache, which could be confused with a symptom of the head injury. Cervicogenic headaches originate in the upper three cervical regions, where the brain misinterprets that trigeminal pain pathway to be a headache, but it's really of cervical origin. So all these different things need to be distinguished, and shameless plug here, I do have a course on headaches if you want to hear more about that.